Hello and welcome to Advanced Health Assessment, Class 58, 705, 521. This set of slides is your first set of slides that I'll expect you to watch and listen to, and then answer questions at the end on Canvas. These sets are about 19 slides, and I'm going to go over exactly what health assessment is. I'm going to briefly talk about health history, and then briefly about interviewing a patient. There is another larger set of slides that I go into in which I expand more on how to interview a patient, because it's very important as part of your health assessment collection, how to interview a patient. So what is health assessment? Health assessment is defined as techniques of a physical exam and history that help you to gather information about the patient from both an objective and a subjective format. The quality of your history as well as your physical exam also lays the foundation for a proper patient assessment, your recommendations of care, and what you plan to do in order to further evaluate your patient. As you go through this class, you're going to learn different ways to assess a patient's system. You're going to learn different clinical skills, and you're also going to learn what each skills mean and what you're going to do about each skill. This is an advanced course in which you're going through and becoming not just a registered nurse proficient in collecting assessment data on a patient, but also what are you going to do with that information as you progress into more of the advanced role, the advanced clinician role. So in the previous slide, I mentioned the words subjective as well as objective data. And it's very important to understand the differences between subjective and objective data. And just by this example alone, this picture, it kind of gives you an idea as to what the differences between subjective data and objective data is. Subjective is anything that the patient tells you. For example, the patient says, "I'm in pain," or the patient says, "I'm dizzy," or the patient says, "I fell down a flight of stairs yesterday." This is information that the patient tells you that you can't really necessarily verify on your own. Objective is sort of the opposite. Objective is data that you collect from the patient. This can be all of your assessment skills that you're going to collect, your heart sounds, your lung sounds, what you heard when you placed the stethoscope on their abdomen, what vital signs you took, what was their blood pressure, what was their heart rate, what was their lab value, what was their ultrasound result. So objective is really anything that you collect from the patient, where subjective is anything the patient tells you that can or cannot be verified. So with nursing assessment or physical assessment or health assessment, you really need to start thinking more critically about the patient. You are going to start to think more along the lines of not just this or that, but what else could there be? Critical thinking in nursing use the hypodeductive model, and this contains 4 major components. It's the ability to attend to initial available cues that the patient is offering to you. It's then the ability to formulate diagnostic hypotheses. The next is to gather data related to that hypothesis. And then the fourth is to evaluate each hypothesis with each new data collected until you arrive at a final diagnosis. So for example, a patient comes in and you initially can kind of tell by their initial cues that, you know what, they might be in pain or they might be upset. just by the way they're looking at you or maybe the way they're sitting in the chair. So formulating a diagnostic hypothesis is possibly that the patient is either in pain or the patient is upset. So you're going to gather data related to that by asking questions of the patient. Does anything hurt, for example? What happened today or what happened yesterday? Very simple questions that you're collecting, your subjective data. You're also collecting objective data. So if the patient, you suspect the patient is in pain, what are their vital signs like? Is their heartbeat very fast? Are they diaphoretic? Are they sweating? Do they feel warm to touch? Or are there other symptoms that are there that might relate to the notion that they might be in pain? And then you're going to evaluate each hypothesis or each question that you have with new data collected in order to arrive at that final diagnosis. So you're going to collect your data by way of subjective and objective data in order to get to your diagnosis of this patient, yes, is in pain, or this patient, yes, is upset, and this is what I'm going to do about it. Nursing process, ADPI, is a method that nurses use to help with our critical thinking skills. By way of the nursing process, we're taking our assessment data, our subjective and our objective data, the question and answer of our subjective, and then our diagnostic, vital signs, heart sounds, lung sounds, bowel sounds of our objective data, and formulating a diagnosis. And your NANDA diagnoses are posted on Canvas, and I'm going to talk a little bit more about the NANDA diagnosis shortly. From the NANDA diagnosis, we'll develop a plan for that patient, we'll implement that plan, and then we'll evaluate. So in this next slide, it's a very basic way to develop a plan of care for a patient based on what your assessment findings are. So again, based on your assessment of the patient tells you they're in pain. So that's your subjective data that the patient is telling you they're in pain. You're assessing that they're in pain based on that. You're also assessing that their pulse rate is elevated. You're also assessing another objective finding is that they are sweating profusely. They're warm to touch. Their blood pressure is elevated. So those are some things that can lead you to come to a diagnosis or a problem that the patient is in pain. What's your plan for that? You're going to decide to give the patient medication that has been ordered, or you might want to consider giving them a warm compress if they have back pain, for example, or something that might help them with the pain or help them resolve the pain. Implementation is pretty much putting your plan in action. It's taking the medication administration and giving them the heating pad and doing all the things for the patient in order to implement your plan and to help alleviate the assessment and diagnosis of pain. And then your final is your evaluation. How are you going to evaluate? You're going to determine whether the outcome of your goals and what you've done for them has been met. So in this situation, patient's been assessed, they're in pain, their diagnosis is pain. Your plan is to give them pain medication. Your implementation is, I gave them pain medication. So now how am I going to evaluate whether their pain has subsided, whether it's been resolved? You can ask them in an hour. You can repeat their vital signs in an hour to see if their vital signs have dropped, if their pulse rate has dropped. And then if through your evaluation it hasn't helped, the pain medication hasn't helped, you're going to go back to the drawing board. You're going to reassess. You're going to re-diagnose. So you're going to reassess, patient is still in pain, patient's pulse remains elevated, patient still complains of pain. I'm still going to diagnose them as having pain. My plan is to call the provider, call the doctor, call the nurse practitioner, and ask for another medication for pain or something else that can help with their pain management. Then I'm going to implement that plan and then reevaluate. The picture on the left shows us the nursing plan or the nursing process as a cyclical method. It's not linear where it doesn't start at assess and end at evaluate, because a lot of times when you reevaluate or when you evaluate, sometimes the plan that you implemented didn't necessarily work, and so you have to go back and reassess. In the comments section, you'll notice there's a link for a video for you to review on what the nursing process is. Please watch the video in order to help you further understand if you're having difficulty. So let's now talk about prioritization of patients. Because sometimes you're going to get more than one patient and you're going to have to decide who do you really want to see first and why. So think about the following 4 cases. You have a 48-year-old male who presents with chest pain. You have a 19-year-old female who has frequent headaches but stable vital signs. You have a 68-year-old male who slipped on a rug. It tells you he slipped on a rug. And you have a 5-year-old boy who has a pencil in his ear. So of those 4, which of the following would you want to see as your first patient, or who really should be your priority patient and why? I'll give you 20 seconds or so to kind of think about it, and then we'll come back and talk. So which patient did you pick? If you picked a 48-year-old male presenting with chest pain, then you're correct. Next slide, setting priorities for nurses. So really, the first patient who you really want to see is any patient that has the ABC rule and the VNL rule, where they might have airway problems, breathing problems, cardiac or circulatory problems. Maybe there's a vital sign concern. You took their vital signs and their blood pressures are very elevated, or their heartbeat is very, very rapid, or their lab values are so much so that they're life-threatening. Your second patients, the patients you would maybe want to see next, are your patients who have maybe a little change in mental status, or maybe they have an untreated medical problem, but can wait for a little while until they get seen, or maybe have complaints of pain or urinary elimination problems. And those are just examples that are given. They're not the end-all be-all of that list, but those are just some examples. And then your tertiary, or your priority 3, are those that are health problems that don't necessarily fit into the first 2 categories. Maybe they are having issues with activity or rest or family coping or lack of knowledge. And these are patients where, if they were in the waiting room, they don't necessarily have to be seen right away. They still have to be seen, but they're not your urgent, I need to take care of this patient now type of situation. So going back to our 4 patients, 48-year-old male who is presenting with chest pain is your first patient. The 68-year-old male who slips on a rug, and maybe even your 5-year-old who has a pencil in his ear, I would say would be your secondary patients. I would probably want to know a little bit more information about the 68-year-old, maybe a little bit more about the 5-year-old, and what does his ear look like specifically to kind of determine who I want to see next. And then your third one is your 19-year-old with frequent headaches, but more importantly, her vital signs are stable. So we're definitely going to see her third or fourth in this situation. But this is someone who, okay, I'm happy with her vital signs, so I'm gonna just kind of wait because I want to attend to this person who might be having a heart attack. The slide is just a reiteration of what we discussed. So again, first is your emergent life-threatening. Second is they require attention, but not so much as the first. Third is they can be addressed, but they're not as urgent. And then when we talk about collaborative problems, which is also something that you're going to learn and you're going to hear about a lot, is when we need to involve other disciplines. So for example, patient who fell, we might want to get radiology involved to make sure that they didn't break a bone. Patients who are having a psychiatric issue or anxiety issues might want to include the discipline of psychiatry or psychology as this patient is being treated. So earlier we talked about collecting data. We talked about collecting subjective data. We talked about collecting objective data. And so you need to know the difference between your subjective and your objective. And remember, your subjective is anything that the patient tells you, while your objective is any data that you collect. There are also 4 other types of data that you're going to be familiar with. And I just put the 2 slides up, so I'm going to go back to that first one. The first one is your total slash your comprehensive, your complete is another way to describe it, health data base. And the second one I'm going to talk about with this one is your episodic or your problem-centered database. And your Bates book on page 5 kind of goes through the list of like, how do you know the difference between the two? Well, the easiest way to figure out like the difference between a total and then like a focused, comprehensive assessment is the information that you get. So for your complete, total, your comprehensive, that's really for somebody who's coming into your practice for the first time and you want to collect a full health history. And we've all been there where we've seen a new practitioner, we've seen a new provider, and they've had us fill out like 10 pages worth of history, or they've sat down with us and our visit was actually much longer than our subsequent visits. This includes a complete health history, so this is all your collection of your subjective data, and we're going to go over what a health history is in a little bit, as well as a full physical examination where you're collecting data from the patient. You're collecting their heart sounds and their lung sounds and anything. Your health history includes current health, past health, and any baselines that maybe measure any future changes or some things that they might be at risk for. And it also yields first diagnoses on the patient. So past health, past medical history, past surgical history, if they're females, what is their menstrual history? Have they ever been pregnant? How many times? How many babies? Do they have any allergies? This is all, anything and everything you wanted to know about the patient. And this is usually your annual assessment. They come in once a year and they get an annual exam done, and you'll collect the full health history. Your problem centered or your episodic or your focused, however you want to term it, there's different ways to call it, is more of your limited or your short-term problems. This is kind of like your mini database, your smaller scope. It's more focused than your complete. So this is somebody who maybe was seen 4 months ago for their annual visit, and then they're coming back to you because they are congested, or they have a sore throat, or they are complaining of ear pain. And so with this situation, a patient comes to see you in the office or the clinic or the hospital, they're not going to have a full, complete health history done because it's already been done a couple of months ago. They're going to have a very short, focused, problem-centered database collection. So patient comes in, they're complaining of ear pain. You're going to focus your health history on that specific ear pain, and you're going to focus your physical exam on their ears, head, eyes, ears, nose, and throat. Anything and everything that has to do with the head always goes together. So you always want to measure all of those systems anyway. So, with that, you're not going to ask them about their last tetanus shot. You're not going to ask them, if they have pain in their ankle, because it has nothing to do with their ear pain. Okay, it's one problem, one Q complex, or one body system. Okay, and again, your history and your exam follow the direction of that presenting complaint or that presenting concern. And sometimes they'll come back in a couple of weeks just for a reevaluation. When talking about the follow-up database, that's just what it was. It's when we've identified a problem. For the ear pain, our focused assessment, we've identified that they have an ear infection. So we said here's some comfort measures. Here are some antibiotics. Let's see you in 2 weeks to follow up and see how it is, or how you're doing, or if you need further treatment. And with that, you're just going to follow up. You're going to note if any changes have occurred, if it's resolved, it's getting better. This can also be given as an example for a patient who was just diagnosed with, let's say, hypertension or high blood pressure, and they were placed on medication, and the practitioner wants to see them on a monthly basis. So follow-up is they're focusing on a specific problem that was diagnosed, and they're just, checking up on them and making sure that their management is appropriate, or if there needs to be a change in their management, or maybe the medications, they need to elevate the dosage to help with their blood pressure. Okay. And then your last one is your emergency database. This is pretty much your ABC, your airway, breathing, and circulation. This is more for rapid collection of data, because in this situation, as in the word emergency, there's an emergency going on, and I don't care what age they were when they got their hepatitis injections, or their hepatitis vaccines rather. Okay, I want to focus on, are they breathing? What's their heart rate? Are they having a heart attack? And focus more on life-saving measures. And everything else, after we save them, then we can go and collect their complete health history. So just a little bit about demographics of the United States, and this information actually was collected in 2011, and I'm sure the data has changed just a little bit, but as you can tell, Hispanics are the largest and fastest growing population in our country, where the Black population are your second largest. There is greater than a third of U.S. residents that are considered other than non-white, non-Hispanic whites. But our population is ever growing and ever increasing. And I like to say this country is a melting pot. And with a melting pot comes different variations of diseases and disorders that we need to be aware of. Asians, American Indians, Alaska Natives, Native Hawaiians, and other Pacific Islanders make up the third largest part of our population. So think to yourself why you believe this information is important to understand as a provider, as a practitioner, as a nurse. In this class, we're also going to learn about how to provide effective care for positive outcomes and satisfaction of the patient. We're not necessarily going to always cure all diseases once they're diagnosed, but as long as we have positive outcomes, then it tells us that we're meeting a standard for our patients. So if a patient comes in and they're diagnosed with high blood pressure, effective care would be part of our teaching them about diet, teaching them about lifestyle change, teaching them about quitting smoking if they're smokers, and teaching them about their medication, and how to take it, and when to take it, and why they're taking it. Being respectful is also another big part of it, of your care, and you learn this um, when you took your seminars class and learned about understanding values and preferences of different cultures and ethnicities, and really focusing on what the patient needs and what are the patient goals, because every patient is different. Every patient has their own needs and wants. Um, and so we have to really elicit what is it that the patient needs and what can be incorporated in their life, that would be appropriate plan when we develop a plan for them. What can be met within their lifestyle. And then again, cultural and linguistic competence. Do our attitudes and policies help our patients, or are we practicing egocentrically, where we believe our culture is better than others? That is not true. We need to be able to understand different cultures, different variations of cultures, um, and if we don't know or we don't understand, we simply ask them and we ask about it and we learn about it. When we start working with different populations, we're going to become familiar with different populations and what their beliefs and what their values are and what they practice. But it's also important that we incorporate their beliefs and their values within our practice and be very mindful and very respectful of that. Steps to cultural competence: you need to understand your own heritage, your own beliefs, your own values, your own practices, but not place that on to another person, but be more respectful as you'd want somebody to respect yours. Being able to identify what health means to the patient. Health for one patient might mean something different to another patient. Somebody who has cancer, their definition of health might mean that they are having a nausea-free day, and today they're healthy. Where to somebody else, health might mean they went to the gym that day or they had 8 glasses of water. Health is different to everybody, so we need to understand what health means to each specific person and how it relates to their culture, back to their ethnicity. We need to understand how our healthcare system works. We need to be health system literate, understand the Affordable Care Act and what that's done. We need to understand the different insurances, what can be covered, and why are we now focused on trying to order the correct tests in order to save our patients money, and knowing what tests to order and what tests to not order. Acquire knowledge about social backgrounds of patients. When we start to work in different populations, different parts of the country, different parts of our, urban cities, we're going to be exposed to different cultures, different experiences, and so we need to be focused on what their beliefs are, what their cultural values are. And if we're not aware, then we need to educate ourselves. And we need to be familiar with different languages, and not necessarily take a class, but be respectful that this person speaks a different language, and how or what can I do to help interpret for them. There are tons of interpretive services out there that can be used, and a ton of community resources. And so, I always say connect with your social worker, because your social worker knows everything. They know the resources. They know how to navigate the system, and don't neglect that. With interpretive services and language barriers, we're also talking about patients who are visually impaired and patients who are hearing impaired. Okay, so that's also counted for this. With the interview process, we want to talk about sitting down with the patient and, more importantly, gathering data from the patient. What is the goal of your interview process? And it's really, the goal is to collect data from the patient and to determine what our next steps are for this patient. It's helping identify health strengths as well as any problems in order to bridge to our physical exam. Okay, our health history collection, our interview, or our data collection, or our health history intake. There's a number of different ways that it can be stated, is just, it's the first and foremost important part of your data collection. It is your sit down session with your patient to collect information from that patient, anything and everything that you needed to know about the patient. It's all the subjective data. And it's really that individual who knows everything about his or her own health state. And the nurse knows nothing. And you remember that. It's the patient who tells you what's going on with them. It's everything that they're giving you. One thing I do want to add is sometimes the individual may come in not being able to speak on their own behalf. Maybe they have dementia, or maybe they are a pediatric patient, or maybe they have somebody else speaking on their behalf. So remember, it's not just that particular individual, but it might also be the individual's representative, guardian, parent, significant other. Okay. When sitting down to talk to them, first important thing before you start really asking questions about the patient is you want to recognize both internal as well as external factors. External factors is everything around the patient, everything around you. You want to ensure privacy because a lot of the information that you're going to be collecting is private. So you want to maintain that privacy, refuse interruptions. If a phone rings, you're going to ignore it. If somebody knocks at the door, or they pop their head in, you want to make sure that you stop talking, or make sure that the patient stops talking so that their privacy remains, okay, that you're maintaining confidentiality. The physical environment. What's the temperature? Is there lighting? Is there seating? Where are you sitting? Are you sitting, face to face? Are you above them? Are you below them? What is their physical environment like? If you're in an emergency room and the environment is all just curtains, is the curtain closed? Are you giving that patient privacy? Dress in professional attire. That's about you. That's about how you are, how you present yourself. What do you look like? Is your hair pulled back? Are your nails clean? Are you wearing your white coat? Are you wearing your nursing scrubs? Are they, neatly ironed? The way you present yourself speaks volumes to how your patients will perceive you, okay, as a professional. Note taking may be unavoidable, and sometimes you're going to need to jot down notes. And it's okay to let the patients know, hey, every so often I'll be jotting some notes down based on what you say. But it's important that you also focus on the patient. Okay, don't keep your head down. You want to have some visual contact with the patient. But then you don't want to not take any notes at all, because like this says, you cannot rely on your memory for details. You do need to write notes, okay? Internal factors, that's your rapport. You have to build a rapport with your patient. Do you like the patient? Well, you're going to love all your patients, of course, but does the patient like you? And I think that's more important. So you got to have that likability factor. You have to come in, introduce yourself, develop that rapport with the patient. Don't seem rushed, because that's the one thing that patients always feel. If they feel rushed, then they don't offer their information. They don't feel comfortable with you. Empathy is that other big one. If a patient tells you something and it's personal, sit and listen. Nod your head. Acknowledge that you listened to them. Acknowledge, that they said something to you that maybe was very personal. And you're not necessarily going to understand everything that they tell you, or be able to relate to everything that they tell you, but it's important to recognize, acknowledge things that they tell you, and let them speak. And the ability to listen is a big one. And a lot of times you want to sit there and just ask them question after question after question, but you also have to listen and let them talk. and try not to interrupt. Pay attention. Have eye contact with them, but not so much that it makes them uncomfortable, but so much that it shows that you're listening and you're nodding your head that you're listening. Asking open and closed questions. So you're probably wondering, what's the difference between an open question and a closed question? An open question is simply a question that you ask that has the ability to provide a lot of information. So tell me, what did you do yesterday? That has the ability to provide a lot of information. Where with closed, it's a yes or no, up or down, black or white type of question. How old are you? I'm 42. Did you eat breakfast this morning? Yes or no? Okay, it's closed. There's not too much that can be answered. But with an open, you're getting a lot more information. A lot of times, if you want to develop a better rapport with the patient, but get a lot of information, open questions are your way to go. So again, this just kind of reinforces the difference between open and closed questions. When talking about open questions, if a patient comes in and they present with complaints of something, what you want to do is be that investigator and ask them more questions about that specific complaint. So I always go to the complaint of pain. And you can use your cold spa mnemonic, or you can use your PQRST mnemonic. Whichever one you want to use is completely up to you. Just remember, these types of questions help to gain more information about a specific complaint. So I'll always say in class, and you're always going to hear me, did you cold spa the question? If they complain of a specific thing, get more information. Be the investigator of that specific complaint. So, for example, patient comes in with pain. If we do the cold spa, what type of pain? When did the pain begin? Where is the pain? How long does the pain last? How severe is the pain on a scale of 1 to 10, with 10 being the worst pain? What number do you give it? What's the pattern maybe? What makes the pain better? What makes the pain worse? Is there something else that coincides with the pain? Like, are you nauseous with the pain? Do you have belly aches with the pain? Do you have diarrhea with the pain? How does it affect you? Does it make you sad? Does it make you angry? Does it make you frustrated? The PQRST, very similar. It's just a different way of phrasing the questions. But these are just two mnemonics to kind of help you investigate. So I have to say this now, you really need to pick one and memorize it and just keep using it, because I'm going to keep asking you this throughout the semester. So what I'd like you to do for the next 20 minutes. The first video is about, I would say, about three minutes long. And the second video is about 13 or 14 minutes long. And I want you to watch both of them because I want you to get an idea of what an interview process should look like. In the comments section are the links to the video. So just if you look to the left, just click on the picture of me, and you'll have the two links that you can click onto, and then a list of questions that I want you to ask yourself as you're reflecting on each of these interviews. The next set of slides I'd like you to watch now is the interview process.